Let's talk about an economic issue for a moment. It occurs to me, and I don't have the numbers, so I'm going to ask you. If you're treating episodic migraines, those are punctate episodes, if you will. But if you're now transitioning to preventive treatment, now you're getting on a drug for a long time, and that's going to incur long-term, predictable chronic costs. How do you determine the criteria to progress from acute therapy, a lot, to chronic therapy? How do you qualify somebody?
Different plans would be different. For us, we're saying 4 migraines a month would qualify you for chronic. Now that said, in Blue Shield of California, you can take any of these preventative medications if your doctor prescribes them. Maybe you only have 2 a month, and there may be added benefit. For example, amitriptyline, also an antidepressant. So there would be other reasons perhaps to take these even if you weren't in that chronic category.
But are doctors complaining that, gee, we want to go on chronic therapy, but you, the dark side of the force, won't let us do it?
Well, I'm happy that our plan does, I think, has a liberal coverage policy. That, I mean, we really don't want our members to be living with this horrible pain that we've talked about and this dysfunction. We want them to be productive members of the community.
You don't want your plan to go broke either.
Right.
Then nobody gets help.
Right, and I think that it's fortunate that there are a lot of options. I mean, there's a lot of things that we need to solve in this complicated area, but there are a lot of options, and many of them are not high cost. We talked about the lifestyle. We talked about some very low cost drugs that can help. And then, unfortunately, there's some folks for whom these measures don't work. And then I think we're going to get to it a little bit later, but I think there are some more expensive new drugs that are going to help those folks who are refractory to the first methods.
Do you insist on step therapy?
At our plan, we have very little step therapy, only in regards to the triptans. We do have some preferred triptans, and so if you have a particular one that only works for you, we may ask you to try a couple other ones first, but other than that, no step therapy.
Are patients getting adequate access to the appropriate medications? Let's not talk about the new ones, but the stuff that's out there that's been wrung out one way or another. Are they getting adequate access, or are the insurance companies blocking it, in your view?
Oh no, I think the access is usually reasonable for these simple things. I mean, as it's just been said, propranolol and amitriptyline are not made out of gold dust. So they're relatively straightforward discussions to have. Sometimes having a discussion around a drug like candacetin is a bit more complex because the evidence is a bit newer. But I think when you have a peer-to-peer discussion, most people aren't unreasonable if you're reasonable with them. If you start out with the idea that everyone's difficult, then you're going to get the result you expect. If you start out with a kind of reasonable discussion about this is why I want to do this, I really don't come across too many problems. I think having a stepped approach where you do the reasonable things first and then you move forward to more expensive things is a perfectly rational way to make sure that disabled people with disabilities like this can get access when they need it.
So how do you go about, I'm going to use you as a straw person,
Okay.
Making sure that the right people get the right drugs and they're not just getting prescriptions plastered for the wrong drugs? How do you work as a
Right.
policeman on this?
Right. Well, so for the newer drugs, I think the more expensive drugs, the more complicated drugs, we do have a prior auth process. And so what that means is you can't just go get a prescription and get it filled. You have your doctor with you has to do some paperwork.
There
right?
it is. I hear the screaming from here to both coasts.
But let me just say, at Blue Shield of California, it's only for us right now for Botox and for some of the newer categories of drugs. So I think for most of them, it's between you and your physician. If it's the right drug, prescribed, and we cover it.
Let me interject here. Botox is cheap, isn't it?
Botox is relatively expensive treatment.
Is it? Is it?
Yes,
So
and
several
very-
$1,000s a year.
And very high copay.
Yeah.
Is that right?
Yeah.
Yeah.
I thought it was being prescribed like water. No? No, not where you come from. I live in New York City. What do I know?
They're paying for it.
New York and LA, we're paying
They're
for it.
paying for it, yeah.
All right. Do you hear a lot of screaming from people with migraine? My doctor wants me to get this. The insurance company's not letting me do it. Do you have to interface here?
In advocacy, you have to teach people how to advocate for themselves.
Is that a yes?
Yes. And if I need to help somebody write a letter to their insurance company, then I will do that, because I shouldn't say many times, but sometimes the process that patients have to go through, there are a lot of brick walls, and you have to get through to the right person to have them understand exactly what it is that you're trying to do, and the consequences if you don't get that
And
done.
that's the huge opportunity. I mean, I think when I think about, we're doing a great job here with our formularies, but making it easier for patients, because health plans can be difficult, and I think that we're causing migraines, right?
Health plans can be difficult. Really? Really?
We're causing migraines.
You might. But there are three moving pieces here, right? There's the person. Are we supposed to use the word patient anymore? There's the person with migraine. Let's be PC. There's the prescriber. And then there's the folks who have to pay for the whole thing and have to maintain some fiscal responsibility here. And they don't always match. They don't always match up. So it's wonderful to sit here and say, we're going to join hands and sing Kumbaya. But my expectation is, and my experience is, that's not what happens. In the real world, there are the barriers, there are the brick walls. So why do we have to fight this? Is it simply for fiscal responsibility, or is there something else?
I mean, I think that's why this forum is so great. I mean, I think it's getting everybody aligned to the well-being of the patients and of our members. I mean, I think we have to do more of this, because I think we do have an aligned vision, which is we want a healthy society, we want these people to be healthy.
Exactly.
But it's what we're up against sort of in our little world. So I think the more we can kind of communicate, and I think it's helpful.
Let me stir up some trouble. How much of your
Too kumbaya.
practice, I do this, how much of your practice is spent in paperwork?
Oh, very little. I delegated.
You delegated. All right. How much, let me do this differently then. He's ducking this one. How much do you delegate?
I delegate everything I can possibly delegate.
How big a stack is this that you've delegated?
Well, I don't know because
Because
I
you've
just delegated.
delegated it. I can tell
I'm
you.
sorry, I delegate.
What I hear is that it's enormous. But I've got someone on staff. I've got 2 people on staff, and all they do all day long is get prior authorizations, right? Is that rational? Is that a good thing?
I think minimizing prior authorizations is the right policy, and at the same time, I think when we're talking about these novel agents that they don't work for everybody, we want to use them sparingly, we want to use them after other things are tried, it is a reasonable approach. Now, that said, I think you can make the prior auth process much easier than it is.
She's talking about really expensive brand new drugs. Is that what you're seeing? Or are you having trouble just getting the basic stuff through?
Well, the problem with the brand new drugs, is that what you're talking
Well,
about?
I'm asking, let's go there in a moment.
Okay.
But those put aside for the moment, the biologics, we're going to get to them.
Right.
But everything else,
No, I don't think that there's a huge issue with people not, if they get in to see their physician, that the physician is prescribing or not prescribing the appropriate medication.
But
Okay,
access to care is an issue,
well,
so that's
one
an
thing.
issue.
But once prescribed, you still have to get this thing authorized and paid.
Right, and then the patient has to continue taking it. And if the side effects are onerous, then you're not going to get very good adherence with the drugs.